haven't used the second one yet.
Okay, good morning everyone. How are you all
Morning.
doing?
Great.
Your grade issues have been taken care of to your satisfaction. I think they put the new grades, isn't it? They changed, Dr. Mo, uploaded the corrected grades. If you haven't checked Blackboard, go ahead, look at it, see if there is any change in your grade. Some people's grade may not change because you already answered, I think, but look into it. Now, for the coming exam, let me clarify, there are 5 lectures, of which Dr. Pafian, 3 lectures given by Dr. Pafian, 1, 2, and 3. And from my side, there are 2 of them, including this one. So, again, 45 questions for PODA 4. Remember, that will be divided by a little number of lectures. Since there are 5 lectures, 45 divided by 5, each lecture will give you 9 points. 9 questions, so 18 points. So I get to write 18 questions, and the remaining will be Dr. Pafian. I think 27 questions from Dr. Pafian, and from my side, 88. So when you review the exam solve, make sure you review the 45 questions coming from PODA 4. The remaining comes from the other course, 639.
Dr. Papian told us he was gonna give us 20 questions.
Only 20?
That's what he said.
Okay, I don't know what's going to happen to the rest of the 7 questions. So he has to write 7 questions or give you free points, 14 points free. That is his, yeah. It is not our choice, it is how the courses are set up. So I cannot say I will give you only 10 questions. That is absurd. So need to demand what happens to the other 7 questions. So the course coordinator has given us this instruction. He also got the same email what I got. So he should write 27 questions. All right, today's lecture, they put me on this pathophysiology, pharmacology. You have to add, there are some discrepancies in the topics, say pathophysiology and pharmacology of hepatitis and cirrhosis. These are liver diseases. I thought of adding medicinal chemistry into it. Then I looked into the core syllabus. It says I get another class just to talk about the medicinal chemistry of the drugs used in hepatitis and cirrhosis. Then I took it out. So it is only today's lecture covers the pathophysiology and pharmacology of liver diseases, hepatitis and cirrhosis specifically. You know, when you were taking biochem in your first semester, probably now you can look back. When you were taking, I was talking about liver, fat metabolism, liver does, and amino acid metabolism, liver, and carbohydrate metabolism, liver. Then what else? Bilirubin metabolism, liver. So everything boils down to liver, liver, liver. So imagine a situation where liver is dysfunctional. Now, of course, with your background, you probably appreciate the importance of liver, and you also, because you are the liaison between the medical and the layperson, you should be able to tell people, save your liver. But one thing about liver is, know liver can regenerate itself? Everyone probably knows by now. So that is the uniqueness of liver. Say, but if the liver on the whole goes bad, it is irreparable, then there is no way it can regenerate. So that's why liver disease doesn't pop up right away. It gives you enough time. But if we don't correct ourselves, then the liver fails. And how many of you know someone in your family or relatives has just got a liver transplant? So that's the only, when the liver goes down completely, only option is get a new liver. And getting a new liver, matching liver, is not that easy. As there is a waiting list, and you have to have a matching. All that the person needs a low one part of the liver. If they get it transplanted, then the liver regenerates by itself. It builds into those 3 lobes. The other missing lobes will be regenerated. So protect the liver. What are the things cause liver diseases? We are going to talk about that tonight. And what will be the drugs? What is the rationale of using certain drugs to cure the liver diseases? If you detect early on, liver disease can be corrected. If it is too late, then it is too late. You cannot save the person's liver. Liver functions, as I mentioned earlier, all the biochemical events taking place in the liver. And you also have studied right now, many of the drugs you studied, first pass metabolism. If anything we take in goes to liver first. So the liver makes the central location where your drug, the exogenously added drugs, or the endogenous metabolites are handled appropriately. So that is why liver function, a functional liver is a must. It metabolizes carbohydrates, fats, proteins. Remember we talked about protein metabolism, nitrogen metabolism. Nitrogen can be metabolized only in liver through urea. A certain degree it can be metabolized in kidney, but it is negligible amount. But the liver is the one makes urea. Urea cycle that we did in biochem, but to get rid of nitrogen, excessive nitrogen or ammonia, liver needs to be there. So that if the liver is failing, all the ammonia developed can cause local toxicity, also can brain toxicity. That's why it is the encephalopathy. That is a condition where the brain gets affected because the accumulation of toxic materials due to inability to detoxify in the liver. Glucose levels. Liver makes glycogen, stores it. When needed, it releases glycogen. By how? You all know how glycogen is mobilized when there is low glucose in the blood. Anyone remember biochem? How does liver maintain glucose level, blood glucose level, when the blood glucose goes down? The breakdown of glycogen. How does it happen? It doesn't happen just like that.
Glycolysis.
That will be breakdown of glucose, glycolysis.
Glucogenesis.
That will be synthesis of glucose.
I'm trying.
I know you're tired, remembering what you studied in first year. Remember, glycogen breakdown into glucose occurs, it is under hormonal control. Glucagon Remember, when glucose is gone, glucagon comes in and makes more glucose. That's how blood glucose levels are maintained, by mobilizing glucose from glycogen, which is stored mainly in liver. That's also a challenge for controlling diabetes, that's true, insulin-dependent diabetes. Remember what happens to people in diabetes? There is a dawn effect. If you study the dawn effect, you already finished endocrinology, right? In PODA. Dawn effect is the person when the insulin is gone, the glucose goes down, glucagon kicks in, comes out of the alpha cells or beta cells, or in pancreas, which secretes glucagon. Alpha cells. Alpha cells secrete glucagon, beta cells secrete insulin in pancreas. So when the absence of the insulin, it makes, but the system thinks, oh, there is low glucose, glucagon is released and it binds to the GPCR, glucagon receptors, which are mainly located in liver. And it activates the glucagon receptor, and the receptor activation causes the pKa. Remember that step, pKa will activate the glycogen breakdown, and it pushes glucose into blood. So the absence of insulin triggers this glucagon to come out. That's why you have to put the patient in long-acting insulin. By doing that, you are cheating the system. Pancreas thinks, oh, there is insulin in the system, so glucagon will not be released. So that will control the dawn effect of making more glucose into the blood, releasing by glucagon. So there are inhibitors of glucagon receptor. So you can block, thereby you can control the blood glucose level during the early morning hours. So that's how you control blood glucose. So overall, liver plays a central role in metabolism of exogenous, endogenous materials, without which we will not be able to survive. But that would not occur overnight. It takes a long time for the liver to go down. Remember, a dysfunctional liver cannot metabolize bilirubin. Bilirubin comes from the daily wear and tear of the red blood cells. Red blood cells survive for so and so months, and then they die. When they die, their hemoglobin comes out. Hemoglobin has all the heme molecules. Heme molecules should be metabolized by producing bilirubin. Bilirubin will not be metabolized unless the liver is functional. That causes the jaundice condition. Cholesterol. Cholesterol is made in liver. Cholesterol is also metabolized in liver. Apart from this, liver provides the immunity against infection, detoxifies toxic compounds, including all the pharmaceutical drugs which you prescribe, your patients take. They need to be digested or detoxified through metabolism by liver. Therefore, a functional liver is a key for a healthy body. Any questions, doubts on this? Do you have need clarification? Ask me. None? What causes liver to fail or liver disease? Infection. Mainly any kind of infection, bacterial, virus infection can cause liver disease or liver to fail. Immunity, compromised immunity, cancer, inherited liver disorders. Other causes include alcohol abuse. Alcohol abuse is the one most important which you need to educate the college goers. Just like you, if these college students would not know what they are doing by binging alcohol. Binging alcohol can damage the liver, may not be overnight. If you keep on doing it, it will cause alcohol-induced liver disease. That is, we will talk about under cirrhosis. Okay? Drug overdoses. It's again your area, but make the patient take only the prescribed dose of the drug. Don't take it more than what is required. Example, Tylenol, for example. Tylenol is one of the toxic compounds which affect the liver function. There is a non-alcoholic fatty liver. Non-alcoholic, alcohol induces fatty liver. Okay, that we will talk about under cirrhosis. Apart from some people, they never drink alcohol. Still they have fatty liver. So that is due to impaired fat metabolism in liver. The liver doesn't know when to stop synthesizing triglycerides, for example. The triglycerides normally produced, they go to adipose tissue, they get deposited. That's what we learned in the normal pathophysiology, in normal biochemistry. That's where they should go. However, if the liver doesn't know when to stop triglyceride synthesis, it will synthesize triglyceride uncontrolled from the carbohydrate which you ingest from glucose specifically. Then it starts storing lipid in liver. That causes the liver to enlarge, and that is called, the person is non-alcoholic. So alcohol also induces fatty liver. There are two, non-alcoholic fatty liver and alcoholic fatty liver. The common problems we are going to talk about in this class is hepatitis and cirrhosis. Hepatic encephalopathy is due to the toxic compound accumulation in liver, which probably spills across the blood-brain barrier, causing the brain to fail. That is encephalopathy. It is the brain, it is the toxic compounds accumulated in liver, also goes into the brain, causing this condition. We are not going to talk about hepatic encephalopathy, only hepatitis and cirrhosis. There are other conditions, but probably not for this class. What is hepatitis? Anything which ends in titis is normally referring to inflammation. That too, virus inflammation. Hepatitis is caused by viruses. Likewise, pancreatitis. It's also caused by viruses. So viral infection can cause liver to fail, liver inability to function. So the inflammation can be drug-induced, toxins-induced, alcohol-induced, parasitic, bacterial infections. In most cases, it is the viral infection that causes hepatitis. There are different kinds of hepatitis. symptoms, I'll come to the types little later. Symptoms will be jaundice. The immediate symptom of liver dysfunction is accumulation of bilirubin in other parts of the body, where it visually visible in the person's cuticle, where the underneath the nails or skin or the eye cornea, they all get a yellow tinge. What is it due to? Accumulation of bilirubin. How bilirubin is excreted? It is excreted through conjugation. Bilirubin is a product of heme metabolism, which is a byproduct of erythrocyte degradation or lysis. So bilirubin do not get conjugated because it's highly lipophilic. So if the liver that occurs in liver, the conjugation process is very sensitive and depends on the functional liver. So if the liver becomes dysfunctional, the early symptom is jaundice-like symptom. And if you test it could be a bloody stool or a black stool or dark urine excretion, loss of appetite, people don't feel like eating, nausea, vomiting, fever, joint pain, swollen ankles, legs and abdomen, itching all over the body. Itching is probably due to accumulation of toxins, because the liver detoxifies, and if they get accumulated, they are the ones causing itching. Nausea, vomiting, believe me, even animals feel the same way. Dogs, a dysfunctional liver, dogs feel that they cannot eat, they vomit, they keep on vomiting, and they don't feel good. Their activity goes down. So these are serious symptoms where if you ignore, it will cause accumulation of fluid and accumulation that will cause detrimental effects. Even if untreated, can lead to death. A person can die without a functional liver. What causes hepatitis, or how many types of hepatitis? There are A, B, C, D, and E types. There are 5 types of hepatitis. Each one of them caused by one or more kinds of viruses. So they are A is caused by virus, it's a hepatitis A virus. Likewise, hepatitis B virus, hepatitis C virus, hepatitis D virus, and hepatitis E virus. For some, there are vaccines available. For example, hepatitis A can be, how is it distributed, how is it passed on from person to person. Hepatitis A, it is through contaminated food or drinking water, contaminated drinking water. It's not dangerous compared to others. It is the least risky, usually recover from the infection. A person can fight it off. It does not cause chronic conditions or lifelong conditions. So hepatitis A is a mild condition, spreads by eating contaminated food or drinking contaminated water. What about B? Hepatitis B virus is a serious condition, and it is spread through infected person's blood, semen, or other body fluid, and sharing needles with infected person. Okay? So it is a physical contact. HB virus, HBV is a serious condition and is spread through physical contact person to person through sexual intercourse or the needles exchange. In case of drug, drug abusers, I would say. It can be acute or chronic disease. Some people are not able to get rid of the virus at all, and it will be lifelong condition. It can lead to cancerous liver disease. Chronic condition is treated with antiviral drugs and vaccines. So HBV, unlike HAV, is a deadly disease. I would say it can cause chronic inflammation of the liver. Likewise, hepatitis C is also a serious condition, spreads through contact with blood of someone with hepatitis C. It can lead to serious conditions like cirrhosis, which we will talk about cirrhosis in the second part, that may develop liver failure or cancer. But there is no vaccine for hepatitis C. And the difference between HBV and HCV is that the virus, in case of HB, the B virus is a DNA virus. Remember, there are RNA viruses, DNA viruses. HBV is a DNA virus. It's not in the note. Please note that in the handout. It's not there. So the hepatitis C is an RNA virus. So your antiviral drugs differ. There is no vaccine for hepatitis C. Need to use universal precautions to avoid exposure. Again, by preventing, it is again physical contact through body fluids and sharing needles. That is similarity between HBV and HCV. But the difference is HBV is caused by a DNA virus, HCV is caused by an RNA virus. And that makes the drugs you use should be different. Antiviral drugs used for HBV are different from HCV. Then the other two conditions, hepatitis B, is caused by hepatitis B virus. It's rare, but it is a serious liver disease condition. And it is through direct contact with infected blood, occurs only if the person is already infected with hepatitis B. This B, its survival is dependent on hepatitis B virus. So there is an interdependence between hepatitis B virus and B as boy virus. So in order for the HDV to kick in, the person should also have HBV infected. So it requires hepatitis B infection prior to HDV infection. So the virus is dependent on HB for some metabolic, or its survival depends on the HBV virus. Preventing hepatitis B, therefore, can be beneficial. So it can prevent the hepatitis D infection. The last one is hepatitis E. It is waterborne acute disease caused by hepatitis E virus. It's due to mainly poor sanitization, which We say it doesn't occur in the US, but it may occur in third world countries where the hygiene of water kind of are not treated well. It may be. That's how it enters the body. No vaccine is available. There is no specific medication available for the treatment of this hepatitis E. It can be prevented by practicing good hygiene and by avoiding eating food or drinking water contaminated with this virus. So there are 5 kinds of hepatitis. Depending on each one of them are caused by a specific virus, like namely A, B, C, D, and E virus. Pathological changes normally you see in this kind of inflammation is periportal injury and inflammation. Portal inflammation, I'm sure you already know this, portal hypertension, portal inflammation, lesions of the bile ducts within the portal spaces is apparent. And there are several kinds of degeneration can occur in the liver, cellular degeneration. It is mainly by apoptosis. Remember, the cells implode themselves. That's how they die, because of the virus infection. So hepatocytes die, and that will lead to formation of fibrosis, or it is also called cirrhosis. So accelerated cell death can lead to accumulation of dead cell debris, which is a fibrosis condition, and leads to the cirrhosis of the liver. And it may trigger autoimmune hepatitis. Autoimmune component of hepatitis could be due to defective T lymphocytes that protect the liver cells. So the T lymphocytes are not unable to get rid of these debris that will lead to the formation of fibrosis, the dead cell accumulation in the liver. Now, what kind of drugs can we use to treat these hepatitis conditions? So drugs that can be used, hepatitis B condition, there can be mainly to inhibit the viral replication. They prevent progress from acute to chronic stage. That is the modality or the purpose of the treatment. Drugs used are antivirals and immunomodulators. In the antiviral class, these are nucleoside and nucleotide analogs. These are nucleotide analogs. As I mentioned earlier, hepatitis B is a DNA virus. So your nucleotide analogs should be aimed at inhibiting the DNA synthesis, DNA replication. So you use like adafovir, entecavir, lamivudine, tenofovir. These are the nucleotides which are targeting the DNA replication of the virus. Immunomodulators, these are interferons. What do you know about interferons? Anything in your previous PODA class? What are these interferons? Are they small molecules, or DNA molecules, or proteins, or what? Small molecules, are they protein in nature, or they are nucleotide analogs, or what kind of molecules are they?
Protein.
These are proteins. They are normally produced by the infected cell the viral infection can trigger the immune response in the cell. And it produces these interferons. These are otherwise called cytokine molecules, or these are protein molecule peptides. When they are produced, they will be released to the outside of this cell, infected cell. Thereby, these interferons will provoke immune response in the neighboring cells. They will say, hey, there is a danger coming in, you better be prepared. So they prepare the neighboring cells by triggering the immune response in those cells. So they are natural anti-inflammatory molecules. So they will trigger the immune response in the non-infected neighboring cells. It is important to know they are produced in the infected cell to evoke or to provoke the immune response from the surrounding cells. It is a wake-up call for the surrounding cells. So the hepatocyte 1 is infected by the virus. Then hepatocyte 1 produces these interferons, and they are local molecules. They are released from this infected cell. Normally, remember, the infected cell eventually dies. It undergoes apoptosis, so it will break open and releases these interferons, and they will trigger the immune response in the neighboring cells as there is a danger coming in. Wake up. It is a wake-up call for the neighboring cells. Therefore, they will better prepared for the virus, which probably infect them later on. There are two kinds of interferons, of alpha 2A, alpha 2B. Interferons, just like any other proteins, they are short-lived because there are proteases, neighboring proteases, and in the interstitial cell fluid that can chew on these interferons and make them inactive. So to prevent the proteolysis of these interferons, these are called pegylated interferons. They are polyethylene glycol. These are man-made. The pegylated are man-made, but they are the normal interferons, alpha 2A, alpha 2B, are produced, and they will give a wake-up call for the neighboring cells to produce immune response to better protect themselves from the attack of the virus. The drugs used, there were interferons. Remember, when they go in, they will be proteolyzed. So they will be short-lived. You can prolong by attaching the polyethylene glycol into the interferons, thereby increasing their half-life. It can go up to 160 hours or more. I will talk about this in the chemistry section, but know this is the difference. There is interferon, there is pegylated interferon. Pegylated interferons are man-made. They are the PEG-conjugated interferons to increase the half-life. Thereby, they stay in the system for a longer time, therefore preparing the cell for the upcoming infection. That's how immunomodulators help. They modulate the immune system of the neighboring cells they can make, they can protect themselves by producing immune bodies which can affect or which can attack the virus. So these are the two classes. These are antivirals, are mainly nucleotide or nucleoside analogs. Since it is a DNA virus, the antiviral agents are all DNA analogs. which can be put into DNA synthesis, thereby they will stop the elongation of the viral DNA. I will come to the chemistry later on, but no, for now, the pharmacology is this. These are analogs. They mimic the natural DNA nucleotides. The system viral system thinks, oh, there is the natural DNA. It incorporates only to find out the elongation process will be terminated. So the DNA molecule will not grow to complete length. Therefore, the virus cannot replicate. That's the mechanism of action. So there are 4 different analogs. Among the different hepatitis viruses, B and C are the more problematic ones, as I mentioned earlier. To prevent acute stage to progress to chronic stage, anti-hepatitis therapy has to be initiated, which you probably learned in your therapeutics. To achieve this goal, antiviral drugs and immunomodulators have to be used. The purpose of the treatment is to inhibit viral replication and elicit, amplify immune response in the neighboring cells and prevent progress of this condition from acute to chronic stage. Reduce complication to avoid need for liver transplant. As I mentioned earlier, the liver transplant, it is, there are thousands of people in the waiting list to get a matching liver. Okay? So to avoid that, go with the antiviral agents or immunomodulators and prevent going from this condition to liver transplant condition. Mechanism of action I already mentioned to you. This edifovir is a prodrug and it needs to be metabolized in order for it to become a active drug. The acyclic nucleotide analog of adenosine monophosphate, that is the edifovir. How is it metabolized? All that it gets a phosphoryl group. It gets phosphorylated to a diphosphate. A monophosphate becomes a diphosphate, and diphosphate becomes a triphosphate. That's when it becomes a nucleotide, so that the viral DNA, the mechanism synthesis, the enzymes think, oh, this is the naturally occurring DNA analog, and they incorporate it, and that will lead to termination of the DNA molecule synthesis. That will inhibit the viral replication. The chemistry part, we will talk about it after the exam. There are no chemistry questions in this section for this exam. Okay, it's only pathophysiology and pharmacology of liver hepatitis and cirrhosis. Now, the lamivudine is little bit different from edifovir or even the tenofovir. The lamivudine is an analog of cytidine. Remember, cytidine is also important for the DNA synthesis. And it is a prodrug. It gets phosphorylated and it becomes a nucleotide, like looking a normal nucleotide, which is a system incorporates. How does it get terminated? Here it lacks the 3' hydroxyl group. Again, I'm going into chemistry, please ignore that part. It will be dealt in the next lecture where we talk about chemistry of these drugs, okay? So all that you know, just like the edifovir, lamivudine is an analog of the nucleotide, but here the difference is edifovir is an adenosine monophosphate Lamivudine is an analog cytidine. Cytidine monophosphate, which gets phosphorylated inside the system, and it gets incorporated. That incorporation will terminate the chain elongation. What about tenofovir? I think the handout had spelled, I made those corrections here. It's Tenofovir. I think I had it in there. I'm using somebody else's slides, by the way. I was teaching only the medchem part until last year or and then this year, because Dr. Rangana is not here, so these are slides I used with her permission. So there were some typos I noticed, made those corrections. Tenofovir is also a prodrug, but it is the deoxyadenosine 5' monophosphate analog DAMP, just like adifovir. It also lacks the 3' hydroxyl group. That's how they terminate elongation. I'll talk to you in chemistry how this 3' hydroxyl group in a nucleotide is important for chain elongation. Remember the phosphodiester bond, which we talked about in first semester, which we probably have forgotten about it now. There is 5', 3', 5', 3'. That's how each nucleotide is linked to the preceding nucleotide. So if the 3' hydroxyl group is missing in the incoming nucleotide, then the successor, the next nucleotide cannot make a phosphodiester bond. So that's how the termination occurs. For chronic hepatitis, you have to use the immunomodulators. Sometimes combined immunomodulators with the antiviral drugs can give you better results. So the immunomodulators, interferons, and they have immunomodulatory function as well as anti-proliferative activities. That means they will inhibit the proliferation of infected cells. So the viral infection, if the host cell is not replicating, that means the virus is also not replicating. Remember, viruses use the host cell replication machinery. They don't have their own. They are parasites when it comes to replication. They have to infect, go into a host cell in order for them to replicate. So but these interferons immune modulate, they increase the awareness of the cells to produce immune modulators. They also inhibit the proliferation of infected cells. There are other antiviral drugs. Here is a sofosbuvir. It's a prodrug metabolized to active antiviral agent. Again, it is phosphorylation. And serves as a defective substrate for viral RNA polymerases. So sofosbuvir, unlike the other two we talked about, it is a adifovir or tenofovir. Sofosbuvir is an RNA polymerase. RNA nucleotide. In order for RNA nucleotide, it is not a deoxy. Remember, only deoxy goes into DNA, and RNA regular nucleotides. So this is sofosbuvir is a RNA polymerase inhibitor. Semiprevir, it's a macrolide protease inhibitor. So that is the difference between adifovir, tenofovir, sofosbuvir. These are all nucleotide analogs, whereas semiprevir is a protease inhibitor. It is not a nucleotide analog. So that's how I study. Someone asked me how to study for this. this is how I compare contrast. Because these are multiple choice questions, you can evaluation and analysis part of the question, you can analyze, okay, what is the difference between drug X, what is and drug Y, and that is how I answer or prepare for the exam. Whereas the ribavirin, it's a guanosine analog. It's also a prodrug, and it undergoes phosphorylation, and it will, when it is incorporated, it will inhibit the RNA nucleotide elongation. Little more on interferons. They are endogenously synthesized signaling proteins that I mentioned earlier. They are released by host cells in response to virus infection, so that they send out the signal to neighboring uninfected cells to produce the cytokines which can overcome that, which can modulate their immune response. A virus-infected cell releases interferons, causing nearby cells to heighten their antiviral defense mechanism. They exhibit antiviral, immunomodulatory, and anti-proliferative activities. Interferons, they modulate all three: antivirus activity, immunomodulatory, and anti-proliferative activities. Interferons now are synthesized by DNA recombinant technology. In the early 80s, when interferons, or even 70s, when the interferons are isolated from the immune cells, there is a JAMA article I read, and the title said, it is costlier than gold. So at that time, interferons were mainly used for attacking the HIV virus. Okay, so that is a hot field. Interferons, work with interferons. Any biochemistry major students dream is to, hey, work with interferons. Okay, so now they are not using any immune cell derived recombinant interferons. They are produced in the microbes using DNA recombinant technology. Recall your biochemistry, molecular biology. We talked about recombinant DNA technology briefly. So you put the human interferon gene into the bacterial, the E. coli or any plasmids, and that's how you amplify production of interferons, human interferons, in the microbe. Then you are injecting the human interferons produced by recombinant DNA technology into patients. Therefore, you don't have that species difference. So there is no reaction to it. Anybody, they can accept these recombinant DNA interferons. There are two types. One is alpha interferon and beta interferon. Alpha interferons are produced by leukocytes. These are the key things which I would remember. Whereas beta interferons are mainly produced by epithelial cells, but both have the same antiviral effect. And alpha interferons has high antiviral activity compared to beta interferons. In alpha, there are two kinds, as I mentioned earlier, alpha 2A and alpha 2B. There are type 2 interferons, but they are not potent antiviral role. The type 1 is the one which has the antiviral. The newer types, or the pegylated interferons. They are conjugated with polyethylene glycol, an inert material which will prolong the half-life of the biologically proteins, interferons. What do they do? The pegylation will decrease the clearance of the interferons. More sustained plasma levels can be achieved. Longer half-lives, as I mentioned, it will be like 168 hours. So better bioavailability. Frequent doses are reduced in comparison to conventional interferon treatment. Remember, because these are proteins, treatment is always through infusion, through IV injections. They cannot be oral treatment. They are very efficient in the management of hepatitis C, and efficacy is further enhanced when you combine the interferons with ribavirin antiviral drug to treat fighting of the hepatitis C condition. Any questions at this point? No? What are the other treatments for hepatitis C? Vaccines. But there are no vaccines for this condition. Vaccines are there for hepatitis A and B conditions. Medical procedures. If hepatitis C or B infection goes beyond chronic and that causes cirrhosis and liver damage occurs and liver needs to be transplanted. So a new liver needs to be added in, removing the old cirrhotic liver or damaged liver. So that's about the viral hepatitis condition. What about non-viral hepatitis? Non-viral hepatitis can occur through alcohol abuse, also through a non-alcoholic condition. It could be mainly genetic, and then autoimmune hepatitis. You know, these days you link it to anything autoimmune. When you do not know the etiology of a specific disease, it can link it to autoimmune disease. So these cells are dying because of an autoimmune response. If our system thinks, good morning.
Okay, Dr. Defo has some issues this morning, so she won't be here, but she will record the lecture and post it on Blog.
Thank you.
Thank you. So as I mentioned earlier, some of you came earlier, later, alcohol can induce hepatitis condition. It's a non-viral hepatitis. The non-alcoholic hepatitis is due to uncontrolled fatty acid synthesis in the liver, which can also lead to enlargement of liver. And autoimmune hepatitis, it can be due to immune system mistakenly destroying its own liver cells. It will be a progressive disease, and if left untreated, can lead to the further damage of liver, leading to cirrhosis, which is fibrotic liver dead cell accumulation. Corticosteroids and other medications such as azathioprine can be used to suppress the immune system. They are the root cause for this autoimmune chronic hepatitis. The That is the belief we have. So the treatment with azathioprine, even cyclosporin, or corticosteroids for prolonged time can induce autoimmune hepatitis condition. Medications. Prolonged use of medications. Say, for example, isoniazid for tuberculosis, the years of treatment. Methyl-dopa for high blood pressure. Phenytoin for a seizure treatment. And macrodantin for urinary tract infections. Drugs like this, we don't know about the statins. Statins also cause a burden to liver to get rid of them, because the statin treatment is a lifelong treatment. And there is, our doctors are so aggressive in treating patients. They want to give the statin no break at all, and they say, yeah, well, liver can take care of it. But what if some people's liver fail because of the chronic statin treatment that we don't know, we don't have any data to link it with? I'll give you a website later on. To go into as a pharmacist, you always check with that link to see if the medication which you are prescribing, about to prescribing to a patient, does it have any history of liver diseases? That's important to check. Okay. Periodic blood tests are warranted. How do we detect hepatitis? By a blood test. What is the test? Remember liver enzymes. Liver enzymes accumulation in blood.
The ALT.
Yes. Those are the liver enzyme tests can be applied to see if the liver is functional. They are, or is it, if any liver damage, these enzymes are released into the blood. These are all aminotransferases. Remember those enzymes, they do the amino acid metabolism. They are involved in it, and they are supposed to be inside the hepatocyte, in the cytosol. If there is a hepatocyte undergoing hepatosis, these enzymes are released into the blood. So that's how we periodically test for these enzymes. If their level is elevated, it is an indicator of, yes, it is, liver is going through some stress. So minimize those enzymes. Or you stop the treatment briefly until the liver enzymes come down. That's monitoring. So that's how you periodic blood tests are required to assess the liver function. Discontinuation of suspected drugs will reverse early inflammation. That is a backfire. You know, you cannot stop the treatment, because if you stop it, the condition can come back. So it is a tricky treatment regime. Rare inherited metabolic disorders of liver, they also can be non-viral hepatitis. They can, like Wilson's disease or hemochromatosis, are the two diseases we can pick up. They can lead to liver chronic hepatitis, but these are not viral. If the hepatitis is untreated and cell death continues, hepatocytes die. As a result, these dead cells, dead tissue becomes harder and harder, and that leads to cirrhosis condition. It's also called fibrosis, liver fibrosis, hardening of the liver. So the fibrosis of the liver caused by many forms of liver diseases and conditions, they are not restricted to only virus on any diseases we talked about. Now, viral or non-viral conditions can lead to cirrhosis if untreated. It is progressively developing liver disease that causes gradual formation of scar tissue. It's also cirrhosis is also called scar tissue formation or dead tissue accumulation by degeneration and destruction of healthy liver cells. Each time liver gets injured, it attempts to repair by itself, but in the process, tough scar tissue forms. As I mentioned early on, liver is unique. It can regenerate itself by removing the dead tissue, but it won't get detached from the liver, so it may accumulate like a scar tissue, a hard dead tissue. The scar tissue distorts the shape of the liver and blocks the flow of blood through the liver, compromising its ability to manage hormone secretion, nutrients production, and detoxification of drugs and toxins. The disease develops over a long time. Its cirrhosis condition is not an overnight situation. It takes years to develop. Therefore, there is plenty of time for the patient to be treated. But if the patient doesn't get any of the treatments we talked about earlier, that will lead to formation of cirrhosis. That cirrhosis condition can be a illness. It's a termination illness unless the person gets a liver transplant. There are two kinds of cirrhosis. Remember, there is still a chance that person can, after forming cirrhosis, if it is a compensated cirrhosis, the liver can regenerate, survive. If it passes that stage, then it will be a decompensated cirrhosis. Patients with CC exhibit no symptoms because there are sufficient healthy cells, hepatocytes, to cover for the damaged cells and scar tissue caused by cirrhosis. The compensated cirrhosis is diagnosed only during checkup or regular blood testing because no symptoms are experienced. Again, so the testing for liver enzymes in the blood can give some indication. Once diagnosed, it is critical to know the cause of the cirrhosis to initiate right treatment. Say if it is coming from alcohol abuse, then stop alcohol intake, period. If it is coming from a chronic treatment of a drug treatment, then stop that drug treatment. Maybe for a short time, give a break to recover, to give time for the liver to recover. The most common causes of cirrhosis are chronic alcohol abuse, chronic viral hepatitis, especially B and C, and non-alcoholic fatty liver disease. In case of decompensated cirrhosis, it's a consequence of too much scarring of liver, that is terminal illness, I would say. And you will see the following signs: jaundice, there is ascites, fluid buildup, bleeding, varices, hepatic encephalopathy. The toxins that build up in the brain can cause neuropsychiatric problems. These toxins are building up because is the inability of liver to detoxify them. So the toxins develop or they build up and they enter brain, and that brain will feel that and it suffers from this condition. Liver disease can lead to kidney and lung disease and liver cancer ultimately, maybe. How do we treat cirrhosis? Only you can make lifestyle changes is by avoiding drinking if it is caused by alcohol, then stop alcohol. If not, get vaccinated for hepatitis B. If it is due to hepatitis B, then get the treatment for hepatitis B. Control weight. And again, it applies to non-alcoholic fatty acid liver disease. If you infuse more carbohydrate, more glucose, remember our body can make fatty acids from glucose. And if it's control weight, then control blood sugar and fat levels and the diet. Avoid excess use of over-the-counter medications such as paracetamol. It's not in here, it's the European countries. You will find paracetamol, ibuprofen, acetaminophen. These are all the liver toxins. We take them over the counter. If we exceed the dose, that's what ultimately can cause liver toxicity. That's why Tylenol is, doctors give you precaution. And Tylenol, you cannot take Tylenol chronically. Antivirals, you can treat the conditions with antiviral drugs such as lamivudine, adefovir, tenofovir, and entecavir. But remember, cirrhosis is already, if it is a decompensated cirrhosis, there is little or nothing these drugs can do. Okay? The ultimate is liver transplant. There are antibiotics because it's inflammation. So the other opportunistic microbes can attack the person. So you can use treat these infections via any of these antibiotics. Medical procedure is liver transplant. Therapies, de-addiction program. If it is alcohol related, then you go with the de-addiction. Or you other narcotics, other addictive drug toxicity, again you go through the de-addiction programs. Now a little bit on drug-induced liver toxicity. I'd like to talk to you on this because you are the ones prescribing medications to your patient, of course, based on the doctor's prescription. But how drugs induce hepatic injury? If this injury can be hepatitis, can be not the fatty liver, or it can be any of the conditions we talked about. So physician prescribed medications, then over-the-counter drugs, herbal and dietary supplements. This one, we all tend to take the herbal medications. We don't know how much stress it will cause to liver to detoxify them. Illicit recreational drugs, they also can cause liver injury. The drug-induced liver injury is also called DILI, D-I-L-I. The environmental non-infectious agents can also cause a liver injury. Incidence is about 10 to 15 per 10,000 to 100,000 persons exposed to prescription medications. About 44,000 people in the United States will experience DILI annually. That is how much prevalent in this country. because we have a tendency to go for anything, everything, medication. We think medication does everything. So there is no natural, give it at the time and when to take your medication. I think we tend to go for, hey, there is a medication, why don't you take it? This makes it costly in terms of not only toll on humans, but also healthcare contributions or expenditures. More than 1,000 agents have been linked to delay and is the single most common reason for drug withdrawal from the market by the FDA. Remember that FDA took it out of the market. We keep on hearing. It is because someone reported it and they probably got several reports of this liver toxicity. So the benefit or the adverse effects outweigh the benefit, then they will take it out. How do they cause liver injury? They can be intrinsic way or the idiosyncratic way, type B, or drug allergy. These are the three ways any of these drugs can cause liver injury. Intrinsic is toxicity, refers to liver toxicity induced by a drug in a predictable and dose-related manner. So doctors know if we increase the dosage, it can lead to liver toxicity. So there is an intrinsic danger of prescribing a drug beyond its concentration, recommended concentration. Idiosyncratic toxicity occurs less frequently. It may be selective for some people. Remember, we all have our own genetic makeup. Our enzyme profiles are different. Some people, they metabolize these drugs, no problem. They are efficient metabolizers. Some people are poor metabolizers. So these drugs accumulate, they have a cumulative effects because the drug cannot be degraded. So usually occurs with new drugs as they are not, sometimes because of the competition maybe, or because of the need. They push the drug, the FDA approves it for public utilization, and that can cause the liver toxicity. When they come to know the liver toxicity cases, that's when they say, hey, we have to withdraw this medication. In some people, drug may induce allergic reactions. It is not common though, it is rare cases. So the doctor can say, okay, you cannot take this drug, I'll substitute with another drug. So that drug allergy is more specific for fewer people. However, frightening complications can result from both prescribed and OTC drugs and also with these HDS drugs. Types of liver disease caused by drugs can be elevation in liver enzymes in blood, that is the first thing happen, and then it can lead to hepatitis, then can lead to steatosis. Steatosis is accumulation of fat in the liver. Then it can lead to cirrhosis. It is the scar tissue formation. Then it can lead to neoplastic lesions. It's malignant hepatic neoplasms or simply cancer, lung cancer. Characterizing the type of liver injury is important for both diagnosis and prognosis. Drug-induced hepatic injury can lead to disruption and destruction of hepatocytes, disruption of transport proteins. Remember the function of the liver in the first, second, or third slide. I have number of functions. So it can be disruption in the transport mechanism of proteins, or it can be cytolytic T cell activation, because the P450 enzymes may be impaired. All the P450 or many of the P450 enzymes are located in liver, remember. That's how liver is an efficient metabolizer of drugs, or toxins, or foreign compounds, or even our own endogenous compounds. In liver cells, they have mitochondria. Some of these drugs may interrupt or disrupt the ATP formation in the mitochondria. Bile duct injury, that's another important aspect. The liver injury can lead to the impairment of bile duct or bile secretion. Bile secretion will impair the absorption of fat, cholesterol from the diet. So these are all interlinked. So anything can happen with the liver injury. How do these drugs induce liver injury? Several mechanisms. It can be production of a metabolite. So the drug comes in and it's metabolized. The metabolite may be toxic for the liver. So it is more like liver committing suicide by metabolizing that enzyme, that the compound. Production of a reactive drug metabolite. Again, that if the metabolite is so reactive, then it can cause the liver damage. It can be due to initiation of systemic hypersensitivity response, drug allergy, and damage to the liver. So there are different mechanisms how the drugs induce toxicity, and this is the website I talked about. You can always check with this link to find out if you are prescribing a drug. Is there a report of daily involved for this drug? So that is another quick way for the pharmacist to look at it, and maybe you can advise the prescriber, hey, there is a report, what do you think? Well, should we prescribe this drug or not? Risk factors for drug-induced liver injury, although it starts off low, not so dangerous, but it prevails. If untreated, it can become deadly, and it can go into requiring a liver transplant. How do you diagnose it? It is again through monitoring liver enzymes. And management of the drug-induced liver injury, withdrawal of the offending agent, of course. That is the first thing you would do. Then you for the corticosteroid therapy or N-acetylcysteine therapy, and also deoxycholic acid therapy. These are all the detoxifying agent. So by giving these medications, you are trying to extract the drug or the toxicant which causes liver injury. These are you can do the attempts you can do to manage the DILE. And here is the government link website which lists. The list keep on accumulating. There are more drugs coming into this link. Pharmacists should routinely consult liver tox for the most current information on DILI, because there is much variation in standard drug compendia and published reports regarding the potential hepatotoxicity of part. That is a note for the pharmacists like you guys. Recommendations, the number of cases of DLI is expected to rise because of the increased availability of the prescription medication. Pharmacists can play an integral role in helping prevent DILI. And to protect their patients, pharmacists must be knowledgeable about the DILI. It is essential to perform all the medication history, a thorough medication history in a patient suspected in experiencing DILI. Once DILI is confirmed, patients should be followed for a minimum of 6 months to assess for the development of chronic injury. Then medication therapy management is one tool pharmacists can use to help identify patients who have DILI, who are at risk for it. So that is the last slide. I'm going to stop at this. So we looked